Good morning, this is Mrs. Terry, and this is going to be a quick review of Chapter 15, Drugs That Affect Urine Output. I posted this morning a lot of notes on an announcement, and you need to read those notes, and they go along with this PowerPoint. So, diuretics are intended responses to decrease edema or swelling and lower blood pressure. The patient's actual blood volume is reduced because the kidneys are putting out more water and electrolytes. So the electrolytes you need to be concerned about, of course, are sodium, chloride, and potassium. And so when you take a diuretic, it increases the urine output. So you would think about the patients and safety issues, such as going to the bathroom. Other safety issues are, especially if it's a first dose, you tell the patient not to get up without calling you. You need to help them to the bathroom, and they can get up, but you need to be very careful, especially if it's that first dose. You always give them, hopefully in the morning, so that they don't get up at night trying to go to the bathroom. And we always keep an INO, and we weigh our patients if they're on diuretics. Of course, complications, hypo and hyperkalemia. And this puts patients at risk for dehydration, something you need to know, because especially in the elderly, they can get dehydrated very, very fast. So I know you're trying to get rid of edema, but you also need to give them fluids so that they don't get dehydrated. With dehydration comes low blood pressure, you've got low volumes, and they can have what we call orthostatic hypotension. So if you're dehydrated, when you get up, you can faint. And so, especially in the elderly, you need to really watch for orthostatic hypotension. Not only if they're on diuretics, but just as they age, their hearts are not pumping as hard as they used to be, and so it takes longer to get that blood when they're in a sitting position up to their brain. And so when you stand them up, if you stand them up rapidly, they're going to faint on you, and their blood pressure is going to bottom out. So you really need to pay attention to orthostatic hypotension. You need to know the signs of dehydration: dried mouth, thirst, dizziness, lethargy, hypotension, etc. Of course, the indications we've talked about: high blood pressure, heart failure, kidney disease, liver disease. Potassium imbalances. You need to know what hypokalemia, what the lab values are, what is dangerous, and how you treat it. You treat it with a potassium supplement, either PO or IV. And they can take K-Dur, and that's an oral potassium. And it should be taken with food or a glass of water because it can make them sick to their stomach. And your renal patients, a lot of your renal patients are on K-Dur. Hyperkalemia, you need to know what that is, what the lab values are. And with hyperkalemia, you give them sometimes K-Exalate, and that gets the potassium out of the body. You need to know about salt substitutes and what you need to teach your patients. Peanut butter and dried fruits have high potassium. Avocados, white beans, yogurt, all of those you can tell your patient that they can take to help with their potassium. Now, you need to know the types of diuretics, and that was your homework. There are thiazide diuretics, loop, and potassium sparing. You need to know about each one of them. I've talked to you about dehydration. We've talked about lab values. You know hypertension, hypotension. You need to know all of those lab values. Potassium sparing. Okay, what does that mean? It's kind of obvious. That diuretic is going to spare the loss of potassium. So what's going to happen? The potassium is going to build up in the body, and they're going to potentially become hyperkalemic. Potassium sparing slows the sodium pump So more sodium and water are excreted as urine, but do not increase the loss of potassium. They spare potassium and keep it in the body. It's not for people with gout or kidney disease or kidney stones because they don't need that excess potassium. Certainly not for patients with renal disease. And if you have too much potassium, you can have heart arrhythmias, tachycardia, you can have muscle twitching, etc. Aldactone is a popular one. Trimeterine is a popular one. Common side effects of potassium sparing is hypotension, low sodium vomiting, diarrhea, and what we said, increased potassium. Thiazide diuretics, they slow down or turn off the salt pumps in the nephron tubes furthest from the capillaries. They cause more sodium, potassium, and water to stay in the urine and leave the body through urination. So blood volume is reduced and blood pressure is reduced. Thiazide diuretics is a very popular diuretic. Now, if you can have fluid and electrolyte imbalances because now you're losing sodium and potassium and water. So you can get excessive potassium depletion or hypokalemia. They can lose all of their or a lot of their potassium, and they'll have leg cramps and arrhythmias. Now, you know, when people say at night they're laying there and they get a leg cramp, and many people say, well, you need to eat a banana. So you can get muscle cramps when you have low potassium. Increased uric acid level, and so that's why people with gout don't need to be taking these, because when you have gout, you have high uric acid, and you don't want it to get higher because then you're going to have an episode of gout. Can lead to hyperglycemia. And like I said, diureal is a very popular one. Loop diuretics slow down or turn off the sodium pumps in the nephron tube in a place different from the thiazide diuretic. You need to know the anatomy of the kidney and know where these tubes are, the nephron tube, and where all of this is affects which part of the kidneys. Again, with loop diuretics, you can get ototoxic, which is ringing in your ears. That's an adverse effect, not a side effect, an adverse effect. You have high potential for low volume, low potassium. We always check potassium levels before giving loop diuretics. Patients can be dizzy, the same thing, low sodium, low potassium. Lasix, very, very common one that you'll give in at home or in the hospital. Demodex is another important one, but you need to check the potassium levels. You can read about overactive bladder and the key points. You can answer these questions. We're going to run on real quick. We've got a few minutes to talk about hypertension. You know the parameters. You've learned that in Skills Lab, and you need to be familiar with those. Healthy arteries are like a fireman's hose. They can dilated, they're open, and constricted arteries are closed up. When they're healthy, they're like a fireman's hose. They expand, dilate, shrink, constrict according to the body's needs. They have arteries have smooth muscle, and therefore they vasodilate and vasoconstrict. Now, if they're clogged, think of a drain pipe or a stopped up line somewhere. The more cholesterol and fats that are in our arteries, the more damage we can have. We can have atherosclerosis and tissue damage and clots. And so vasoconstriction then, by common sense, blood's not going to flow. And therefore, the heart is having to pump stronger and harder to get past those clogged arteries. The veins in your legs are having to try to get the blood through the veins, and they're working against a dilated vessel. They're clogged. Hardened arteries. What causes them? Smoking, hypertension, diabetes, a lot of things. Healthy ones, more hardened, are when it's unmanaged over time, they get hard and they're not flexible like our normal arteries are. I'll talk to you about this. The more pressure the heart has to push against, that raises your blood pressure, and it also causes heart failure. Low blood volume from anemia or dehydration or blood loss can reduce blood pressure in the body. If you have a strong water pump, then everything flows good. Hypertension and high blood pressure can damage the inside of the veins, and hypertension is the number one culprit of all of these diseases. Vasodilation, just think of water hoses and your shower heads and that kind of pressure. What do you need to do? You need to exercise, eat right, get your blood pressure down, get your blood pressure under control. And patients cannot stop taking their blood pressure medicine unless the doctor tells them to. It's a lifelong, normally, disease. Cardiac output is the in relationship to systemic vascular resistance. So the resistance that the blood is having to push against affects the cardiac output. So if the heart is having to push harder, it's not going to empty its chambers in the heart. The blood is not going to get around. Cardiac output then is determined by the heart rate and the stroke volume. An increase in heart rate or stroke volume results in an increase in cardiac output. So if the heart can push out a lot of blood, and then your cardiac output is going to be increased. And your blood pressure is going to go up. You know about the chambers of the heart, the aorta, the pulmonic valve, etc. So, the body needs to be in homeostasis. It needs to always, your blood pressure needs to be controlled so that the cardiac system will work and vasodilation will occur. The blood can get pumped out. If you have vasodilation, it's going to decrease the amount of cardiac output because the heart's not pumping as hard. The kidneys react with increased urine if you have low blood volume, etc. So you can see that everything we do in our body affects another part of the body. Really study this. It's very interesting. And that's how you maintain homeostasis. You need to know the types of antihypertensive drugs, diuretics we've already talked about, ACE inhibitors, ARBs, calcium channel blockers, beta blockers, alpha beta blockers, central acting adrenergic agents, and direct vasodilators. ACE inhibitors, please remember they end in pril. You need to know the endings of these categories of drugs. So if you see something called benazepril, captopril, then you're going to know automatically that's an ACE inhibitor. Here's the side effects. This causes vasodilation, what we just talked about. Therefore, it lowers blood pressure and it decreases the blood volume and reduces that vascular resistance that the heart has to push against. So all of that with the vasodilation causes that blood pressure to go down. Now you must watch for angioedema. This is an adverse effect. This is not a side effect. This is an adverse effect. You'll get swelling in the face. If they say, my tongue is tingling, my mouth is tingling, whatever, you pay attention to them because they can die with angioedema. You always have to know, you need to think of airway first. And if that airway looks like it's getting compromised, then you need to handle it emergency. I'm going to let you read about ACE inhibitors, angiotensin II receptors. They end in sartan. Losartan, valsartan. Again, they can cause dilation. So you think about that they can have low blood pressure and faint. Calcium channel blockers. What do? They block the calcium, and therefore the heart kind of calms down because calcium is one of the main chemicals in the heart. And they block the calcium from the muscle cell. The heart is a muscle, and the heart and arteries. So they block all of that. And Procardia, Cardizem, Norvasac. So they slow the cardiac muscle contraction, which lowers the heart rate. They relax smooth muscle. They widen it. That decreases that resistance, causing vasodilation. A side effect would be tachycardia and hypotension. So always check their blood pressure and their heart rate. Beta, adrenergic blockers, beta blockers. Beta blockers end in LOL or OLOL. Metoprolol, propranolol, atenolol, those are beta. Some are beta 1, some are beta 2. You need to know the difference. A side effect of a beta blocker is a low heart rate. It also decreases how hard the heart pumps. Again, do not stop taking it because you can get severe hypertension. Alpha blockers. This is beta, this is alpha. It blocks the smooth muscle and arteries. So these are used for prostate problems and bladder problems, to relax the muscles in the prostate. And they can cause vasodilation throughout the body. Cardura, Minipress, Hytrin. Alpha beta, Coreg, and labetalol. They lower the heart rate and vasodilate. You need to know every one of these. Central acting adrenergic agents, clonidine, methylidopa, they act to stimulate the CNS system to decrease constriction of the blood. So they work on the CNS, central acting, CNS, central acting. You're going to get dry mouth, nasal congestion, all that kind of stuff. This you need to study and see where each one of them act on the body. So interesting. Hypotension, we've talked about. Diuretics, you know about that. Chapter 17, drug therapy for heart failure. What is heart failure? There's left-sided, right-sided. You need to know this. Left-sided means lung. They're going to have a lot of stuff going on in their lungs. Decreased urine output, a lot of wheezing, froth, coughing. Right-sided, they're going to have jugular vein distension, abdominal distension, liver swollen hands, weight gain, etc. So it's more within the system, within your body. This is lung. So in heart failure, the heart is not the myocardium of the left ventricle, causes a backup of blood into the lungs. Remember, the left ventricle pumps that blood into the lungs. And if there's left-sided heart failure, then it can't get that blood into the lungs. The three characteristics of heart are the force, how hard is the heart pumping, the rate, and the speed of the conduction through the heart. Those are the three things that have to be working in the heart in order to have a normal function. How do you reduce your blood pressure? You can read that. There are many causes of hypertension. We talked about beta blockers, vasodilators. That's nitroglycerin. Think of that. That's a dilator. It can be given topically, IV, sublingually. You must wear gloves or you're going to get a great big old headache. And the patients usually get a headache. Isodil is usually given when there's severe heart failure. Apresilene is a common vasodilator. You make sure you know about sublingual nitroglycerin. When you use it, what do you tell the patients? When you call the doctor, etc. Cardiac glycosides, that's lanoxin. Lanoxin helps the heart contract stronger. And it helps the heart pump more effectively, slower and stronger. The thing about lanoxin is you can get toxic, big time toxic. You need to know the lab values. You know you have to watch the lab values. Before you ever give lanoxin or digoxin, you take an apical heart rate before every dose for the rest of your nursing career. And if it's less than 60 or greater than 100, you hold the medicine and call the doctor. You have to take it an apical for a full minute, not 15 seconds times 4. You take it a full minute with every dose of lanoxin digoxin. You call the doctor if the heart rate's less than 60 or greater than 100. You know these lab values. You know to watch for toxicity. They can die if they have that. If they weigh more than 2 pounds a day increase, you need to let the doctor know. Natriuretic peptides is a hormone that is produced by the heart ventricles, and it helps the kidney excrete more sodium and water, and it causes vasodilation. Positive inotropes are heart pump drugs. They're heart pump that make the heart muscle contract more forcefully. Dobutamine, dopamine. Those are usually given in an intensive care setting. If the blood pressure is really low, you'll hang a dopamine drip or a dobutamine drip, and then you've got to watch so that you don't put them in tachycardia, etc. So read this. You'll know if they're having exacerbation if they gain more than 3 pounds a week or 2 to 3 pounds a week, if they're getting more swelling in their ankles, if their shortness of breath is getting worse, or if they're telling you that they feel bad. So be sure to know all the key points so that you can recognize if their heart failure is getting worse. And that's a rapid review of Unit 2, and I hope you gained some information.